My case, 36-year-old female, road traffic accident, had a basic cervical neck of femur fracture, was treated with ORIF with nailing elsewhere. Patient has got pain in the right hip. This X-ray is the one which was available at the time, 4 months post-op from the initial surgery. So this is how the patient came.
What do you want? Let's ask the panel what they would do. From the other end?
Yeah, he's just 36-year-old, and only that almost it is the neck is almost absorbed. Reconstruction is really a tricky thing. Maybe we need to give a good quality life. Probably we should think of a total hip.
Cemented, non-cemented, length of your implant, do you want to bypass the last screws?
Yes, ideally if you go to the non-cemented, maybe the bowing is coming in the picture. I don't know the length of the nail. I need to measure the length and
go beyond the screws?
Going beyond the screw is ideal thing. But the medullary canal is very narrow, and my Wagner type of stem will go there. Otherwise, modular type of earlier reasonable stems are there. We can use it.
The next person.
On 36-year-old, if the osteosynthesis option is completely out, since if the trauma people doesn't want to take it up for osteosynthesis, I will also go for total hip. My implant option will be again distal fitting kind of stumps.
What is it?
There are
distal fitting stumps.
There are subtle signs of infection with a lot of lysis around the screws, lower screws showing some lysis. I will be ruling out infection strongly first, maybe 2-stage.
2-stage. Next.
Yeah, single stage.
Be quick because we don't have much time. Yeah.
Distal fitting stem total hip replacement.
Single stage.
Ruling out the infections.
Vijay?
Infection has to be ruled out, but strictly not a distal fitting stem. Because a young patient, so I'll put maybe something like a cone Wagner, and if the stress raises a problem, I'll run a plate. Strictly, I will not do a distal fitting stem in this patient.
Amar, you would do the same?
I mean, I would get a CT scan. I would get my trauma guys involved. I would see if there's any possibility for removing this hardware and doing a better reconstruction. If I was going to end up doing a total hip, I would do a short Wagner type stem. I wouldn't worry about the distal screws. She's got good bone. You just keep her on crutches for 6 weeks. If you have any concern, you could put a plate on the outside of it, but I would not try to bypass those screws. It would entail putting too long a stem in. That would cause more problems.
Pradeep, anything different than these?
No, a short stem and fill the skull with the screw up bone.
Yeah. Rajkumar, what did you do?
So this is 9 months post-fixation. So again, the patient was, the surgeon was waiting, and 1 year later, this was the situation. So the surgeon had removed the head screw, and the patient started walking with this, and then started developing difficulty in walking and severe pain. Anybody in this stage, any important points to be noted?
You want to comment? Vijay?
What was the surgeon attempting? I'm not...
1 year post-surgery.
The patient was having pain, so he removed the screw, but now this patient started having difficulty in walking. Yes, this needs a THR, but anything specific now? Okay, so now the patient has got pain and difficulty in walking. So now you can see the infections is ruled out. The challenges were in this case, 36-year-old female, as the panelist said, young, femoral head AVN, protruding implant, very long IM nail and a distal screw is down. Patient was walking with this prominent nail and the implant option, so that was discussed. So
Rajkumar, you have to finish fast. Go ahead.
So perioperatively, so this was the situation. Because of the prominent nail, the patient was walking with that, it has damaged the abductors and it was almost very much thin fiber, so I had to reinforce the abductors completely with this ethibond, and I had to tighten up that, and then went and did this. Yes, I really like that point was discussed. In fact, I was also thinking about that, but I didn't want to have an issue of stress raiser and a fracture again, and this patient already underwent a couple of surgeries. So I had to use this, bypass the screw length, but I used a dual mobility and a 44 size cup and a distal loading sum, and this is a 2 years post-op X-ray. Any comments?
Any comments?
Looks good. Again, I mean, the point I want to make is you don't have to bypass. We've put it into your heads this person has good bone. You know, you can go short stem and put a plate on the outside if you really are nervous, you know, or just keep them on crutches for 6 weeks. After 6 weeks, that is mitigated. So bypassing things, I think sometimes we spend too much time. You need to weigh the risks of bypassing something versus just going shorter.
Okay. Thank you, Rajkumar.
Thank you.